Welcome back to Quick Hits, the podcast where we dive into the latest trends and innovations in healthcare technology. I'm your host, Tyler Smith, joined as always by Ken Booth. Today we have a very special guest, Dr. Aaron Neinstein, the Chief Medical Officer at Notable. Dr. Neinstein brings a unique perspective to the field of healthcare technology, having started his career as a clinician before transitioning into informatics and digital health. During our conversation, he shares his fascinating journey, from a chance hallway meeting that launched his informatics career, to founding a startup focused on diabetes technology, to now leading the charge at Notable to automate administrative workflows and reduce burden on healthcare providers. Dr. Neinstein provides insights into the critical role that AI and automation will play in addressing the growing challenges facing our healthcare system, from an aging population to provider burnout. He explains Notable's approach to identifying high-impact, low-risk use cases for AI and paints a vision of a future where technology helps restore the doctor-patient relationship. We're thrilled to have Dr. Neinstein on the show today to discuss the exciting intersection of healthcare and technology. Don't forget to follow us on your favorite podcasting platform, and please enjoy this episode.
And welcome to another episode of Quick Hits. I'm your host, Ken Booth, joined as always by my co-host, Tyler Smith. Tyler, how are you today?
Great to be here, Ken.
Great. Yeah, we have a great conversation that I know we're both looking forward to. For all of you who are long-term listeners to Quick Hits, one company has come up a few times, and that is Notable. So I'm really excited that we have the Chief Medical Officer at Notable, Dr. Aaron Neinstein, joining us today. Dr. Neinstein, welcome to the show.
Thanks. Really excited to be here.
Yeah, us too. And we're really looking forward to diving into digital health and talking about the role of AI. But first, we'd like to get to know a little bit about your background and how you ended up in your current position at Notable.
Yeah. So, one of my career mentors is Bob Wachter, and he always has described himself as what happened when a political scientist went to medical school. And I think I'm what happened when an American studies major went to medical school. So I was always much more interested in reading things like Harvard Business Review or Health Affairs than I was Nature or Science. Very focused on sort of the human and systems and that side of medicine than on the deep science portion. And so as I came up through medical school and residency, got much more involved, health IT was starting to become a big deal 15, 20 years ago. And as I was coming out of my residency training, happened to have a hallway conversation with UCSF's chief medical officer at the time, Dr. Adrienne Green, who said that we had, she was asking me what I was interested in my career. When I told her, what I was interested in, she said, "Oh, we just signed a contract with this company called Epic. We need doctors who are interested in helping out with the implementation." And I said, "That sounds really interesting. Sign me up." And so, at that time, there were not a lot of people interested in informatics. Nowadays, there would be a hefty competition for a role like that. But all I had to do was raise my hand in the hallway and say yes. And I was on my way to a career in informatics. And since then, during my endocrine fellowship, helped start a company called Tidepool that builds software for people with diabetes, sort of integrating device data from insulin pumps and continuous glucose monitors. Worked at UCSF for another decade building out digital health programs across patient access and remote patient monitoring and telehealth, and then found my way to Notable mid-2023 as Chief Medical Officer.
Well, that's an awesome journey. Again, we really enjoy when someone has a clinical background and then they begin to gravitate toward the technical, specifically in your case to digital health. So let's talk a little bit about Notable. As the Chief Medical Officer at Notable, what are some of your most exciting projects that you've either worked on in the past or maybe that you see coming up when it comes to healthcare automation?
Yeah, so at Notable, our mission is really all centered around how we remove burden and administrative friction from healthcare systems. So Anybody who's spent time in a clinical practice or in the hospital knows that so much time, effort, friction, and waste exists in the healthcare system around administrative tasks. And so, whether that's working work queues, answering phone calls, faxes coming in off the fax machine, dealing with prior authorizations, there's just an immense and growing amount of barriers and friction in between patients and providers being able to, for patients, get the care that they want, for providers, deliver the care that they want to give. And so, Notable is all about removing that friction, removing the barriers, and shrinking the distance between the care that care teams want to provide and that they're able to deliver to patients. And so we do that through AI technology that helps automate workflows. So anywhere you go in a healthcare system and you see people kind of, banging their heads against a table, doing repetitive work over and over, and you wonder, why is it that humans are doing that repetitive task? Those are opportunities for Notable to come in to augment and support existing workflows and the workforce, and help them get their work done faster, and help patients get the care they need. So a couple of examples. So we do this for value-based care organizations. If you think about the work, value-based care is a very human, labor-intensive process to do well. Well, why is that? Well, it's because it takes an army of humans to review and scrub charts to identify the health maintenance activities, the care gaps, the cancer screenings, et cetera, that patients are having and whether they're up to date. It takes an army of humans to do outreach to patients to help close those care gaps. It takes an army of humans to scrub the charts for risk adjustment and to do proper coding. It takes an army of humans to reach out to patients about care management and program opportunities, that diabetes prevention program that they want to enroll in. And so every step along the way, there's opportunities to automate those workflows, automated chart reviews, automated outreach to patients, automated offers of care management program enrollment opportunities. And so, very passionate about the work that Notable is doing there to support value-based care organizations. And if you look at organizations that are primarily fee for service, it's the same thing if you think about the referrals and patient access process. So everything from the referral coming in on the fax machine, to the authorization being done, to the appointment being scheduled, to the pre-appointment intake, takes just an army of getting through, an army of humans to get through all of the friction and the steps in the workflow that exists today. And so we serve to automate those tasks, and very passionate about what we do there.
It's appropriate to say that a lot of these areas call for an army of humans. And we know that's kind of the biggest challenges that a lot of organizations are facing right now, just not enough people. Let's talk a little bit about the pandemic. So since COVID-19, or even during COVID-19, how did you personally see things change, or at least the attitude toward automation and AI? Before you joined Notable, you said that it was you joined there in 2023. So prior to that, what did you experience?
Yeah, 2023. So I think, as we all saw, the pandemic was an accelerant for digital health. There were many, many use cases that were sort of sitting on the sidelines waiting to be given a chance, that moved forward very rapidly during COVID. Obviously, telehealth took off. A lot of different patient engagement technologies took off. I think stepping back from the pandemic, though, the macro trends that we're seeing across the ecosystem are more concerning, more troubling, and I think more important for us to focus on. So if you look at the aging of the baby boomer population, so we're seeing the population age, more chronic conditions are being accumulated. So we're facing an older, sicker population of patients in the United States. At the same time, also again accelerated by COVID, but not just through COVID, burnout among care teams. We see nurses leaving the workforce. We see 2 million open administrative healthcare jobs across the country that are unfilled. We see providers leaving the workforce. an estimated, I think, 20 to 25% of primary care providers leaving the workforce over the next 5 to 10 years. We see articles recently about uh, physicians wanting to work fewer hours. So not only are more physicians leaving the workforce, but those who are staying in the workforce are working fewer hours than in the past. And so you have this tsunami hitting the country of more older, sicker patients and fewer care teams and fewer providers to take care of them. And so the way I look at the what's facing us with artificial intelligence is it's not going to be a nice to have. It's not going to be a nice thing that we should do. It's going to be an imperative, because the only way we're already seeing care teams today struggling to keep up, suffering with burden, overwhelmed by the amount of administrative tasks they have to do to take care of patients. And that's for, panel sizes of 2,000 patients per primary care doctor. What happens when we have fewer primary care doctors, patients are sicker, and we have more patients on Medicare? How are we going to take care of that population and deliver the experience and the access that we all want to? I think that we're in a place where we need artificial intelligence to help eliminate the extra tasks and eliminate a lot of the administrative friction and get to a point where we can deliver better care to more patients than we're able to do today.
When you talk about automating these points of friction, what's the approach for Notable? Like, how do you determine what can safely be automated?
Yeah. So, I'm as a good informaticist, I think of life as a series of 2x2s to help prioritize things. And in this sense, I think of the 2x2 of sort of risk versus impact. So, what are the things that we can do that are going to have the highest impact, the highest value for care delivery, and the lowest risk? Because we can all think of things that might be really cool to do. I was talking with someone earlier today about AI diagnosis. Sounds really cool. There was so much focus there, 10 years ago in the AI space, but that's not actually the problem facing doctors today. So maybe not the highest impact and super high risk. However, turns out there's a lot of things we can do that will have incredibly high impact and are pretty low risk. So faxes coming in on the fax machine that comprise referrals to specialty care. Every minute, every hour, every day, every week that those referrals are sitting on the fax machines, patients' care is being delayed. Their ability to see oncology, their ability to see cardiology. It's a pretty low risk thing to do, to use AI to transcribe that fax, get it into the EHR faster, move it through the system and the work queue faster. So high impact to patient care and the business, because healthcare organizations are paying dozens of people to literally transcribe those faxes into the EHR. Low risk. Prior authorizations. If you look at work queues, we looked at a healthcare organization last week, 7,000 active work queues for administrative tasks in their EHR. So that includes revenue cycle work queues, that includes authorization work queues, that includes scheduling and referrals work queues. Every single row in those work queues is a patient waiting for a task so they can get their care. It's a person with cancer waiting to get their chemotherapy, to get that infusion approved. It's a person with cancer waiting for their PET scan to be approved. And so we can automate a lot of the work behind those authorizations. And again, low risk, very high impact. So I think there's all of these use cases that are right in front of us that we're working on today that have a combination, as you think about that 2x2 in your mind, high impact, low risk.
Yeah, Dr. Neinstein, I love this because the diagnostics example is easy to understand why people see AI and why they immediately go to the pieces of healthcare that everybody encounters. But with your background, it's really cool to hear how you humanize the work queues and how that actual work, is just as important, and actually can be tackled without, the risk of a lot of the other pieces, the fear that people have of AI in healthcare.
Yeah, I think if you think about anybody listening to this, and yourself included, your last interaction with the healthcare system, my guess is most likely you were frustrated by some silly administrative task that got in the way. Your
Hmm.
prescription wasn't sent to the pharmacy. A prior authorization was sitting in someone's pile for too long. The referral didn't get sent. The wrong billing code was coded from the chart. The bill was confusing and you couldn't understand it, and or maybe there were errors in it. And so there's all of these things that comprise the care that we get. And so people always think about healthcare as being the interaction between the doctor and the patient, and honestly that's what it should be, but it's all
Right.
this other stuff that gets in the way and actually inhibits people from getting the care that they need. So I loved in Eric Topol's last book, he had a quote that was something like, we don't need AI to cure cancer. We the opportunity afforded by AI is to actually restore the trust and the relationship between the doctor and the patient. I think Eric got it exactly right there.
Yeah, and love the quote of Eric Topol, also Robert Wachter. Um, we the digital doctor was actually a giveaway at a HTM conference many years ago. I'm sure Ken still has his copy.
It's on the shelf.
It's a great
There we
book.
go. So Ken asked a question around, yeah, essentially the aging population, and I'll ask you, actually also ask you to make another kind of prediction in terms of, yeah, the AI adoption curve. We had a really good conversation with Dr. Pfeffer from Stanford, and he basically said we're at this automation phase. So curious to how you kind of put, or categorize the AI, the progress that we're making in healthcare, and maybe how you look at the life cycle or the curve, or however you see the timelines going into the future.
I think the fascinating thing is that the organizations who are making the best use of AI paradoxically are not necessarily the ones that are focused on AI. And so what I mean by that is that there are organizations who are thinking about AI as like its own strategy. And then there are organizations that understand what they do as a healthcare delivery system. I am the best value-based care organization. I am the best rural health provider in America. I am the best urban health system that takes care of marginalized populations. And they know for their strategy, for their mission, for their focus, what their business challenges are, what the challenges are in their care delivery system. And they can point AI at their specific problems, their specific opportunities, their specific strategies. And we actually see those organizations performing the best with AI because they're not thinking about it from the lens of AI, but just this is a tool that is really powerful to help me meet the needs of my stakeholders, to meet the needs of my providers, my care teams, my patients. And so to me, that's the most correlated thing with AI adoption is, again, paradoxically not focusing on AI, but actually just organizations that understand where they have challenges, where AI can be useful.
So it's safe to say AI is just a tool, not the tool.
That's right.
Essentially, we're not to the point where we can fully trust AI, for example, to make diagnoses, correct?
That's right. It's it's getting to the point where there are many workflows where we can leverage AI, where it's having your best call center agent, or having your best medical assistant, or having your best medical student in a task focused way helping you perform the tasks you need. And I think one of the really exciting things, and a frame shift for people, is so often in the care delivery system, we are constrained by what we've seen through history, which is the only way I can solve problems, the only way I can, grow the volume of patients I see, the only way I can staff my call center, the only way I can respond to in-basket messages, the only way I can check patients in for appointments is by going to my CFO and asking for more staff to staff more people. Well, think about where that's left us today. So if you think about a patient being discharged from the hospital after having a hip replacement, is anybody calling to check on them? If you think about a pre-op before somebody goes in for a cardiac valve replacement, how much time is being spent with the patient on the phone to walk them through the pre-op, to make sure they've got the education, to ask them the right questions? So what becomes possible when we can actually use AI agents to augment our workforce to do those tasks at scale? So, imagine what could be possible if you didn't have to go to your CFO and ask for 100 people to do post-op phone calls, check-ins with patients. What does it look like if you have a limitless ability to screen patients before their colonoscopy, before their valve replacement, for the basic questions that would be asked, but you just don't have enough staff to do that work today? So you can start to envision really an entirely different healthcare system than we have today, where today we think about concierge care as something that's only available to very few people, but that's because of the resource costs. As those resource costs come down and you can automate more of those tasks, we imagine a world where really everybody can have that level of concierge access, care, and service and experience. And so I think we're headed to a really exciting place there. Obviously, lots of things we need to be very careful with around AI, and lots of concerning possibilities, but also some really exciting ones.
And you mentioned Typool. So, yeah, would love to hear a little bit more about your work with Typool and how that reflects the shift towards open source solutions in healthcare.
Yeah, so Tidepool, let's see, we started it in about 2012. And at the time, every single insulin pump, every single blood glucose meter, every single continuous glucose meter had its own software that was proprietary and closed. And so as a provider, every morning when I sat down to see patients coming in for the day, literally had to open, you're going to have to sit down for this one, 8 to 10 different web portals. So for every different vendor, they had their own portal that we had to log on to and use to download information from that vendor's pump, CGM, glucose meter. And it struck me as crazy. And if you talk to any single one of those vendors, they would say, "Oh, our software is the best. If you just use our software, your work will be super easy. Your world will be great." And what none of them could admit to themselves is that that's not how enterprise software works. That patients were going to, no matter what they did, they were not going to have 100% market share. There was no world in which Medtronic had 100% of the insulin pumps, or where Abbott had 100% of the continuous glucose meters used in my office. And so there needed to be tools that allowed providers to have a similar workflow no matter what devices the patients were using. And here we were, in the mid 2010s, in this, world moving towards TEFCA, moving towards 21st. This was pre 21st Century Cures, but pretty soon thereafter, we hit 21st Century Cures Act, which said that patients in the United States had a right to access their healthcare information in any way that they chose. And here we were with all of these data for people with type 1 diabetes, taking, care of a life or death situation, and they couldn't actually access their own data in a manner of their choosing. And so Tidepool was all about streamlining the workflows, unlocking the data so that patient and provider could actually access it in an easy, standard way, and have made great progress on that front, both with Tidepool and in the diabetes ecosystem. But obviously, at the same time, nationally, there's been so much progress on patient access to data. It's been really exciting to see.
Can I ask what led to the focus on diabetic care? Because that's great. I mean, you had a deep understanding, you understood the challenges and the workflow of all of those different technologies and the web portals. What led you to realizing that there was potential there and that there was a need for solutions there?
At the time I was in my endocrinology. I'm an endocrinologist now. At the time, I was in my endocrinology fellowship, and so had just come off the heels of helping to implement Epic. So had that informatics training under my belt. Felt the daily pain of trying to download and use all of these device data, and also extremely fortunate to be practicing in San Francisco in the Bay Area, where many parents of kids with diabetes were in the software industry, and so had some incredible partners. Our founder and CEO, Howard Look, had a daughter with type 1 diabetes diagnosed around that time, and so just incredible energy from the parent community of kids with type 1 to help move that forward.
That makes sense. A lot of passion driving change in that industry. Well, I guess that's kind of leads us to our next question. What advancements or what other advancements in diabetic technology have you seen that has had a lot of impact or the most impact on some of these patient outcomes?
Well, so it's a great question. I joke to people that I had a very interesting an exciting 2023 as someone whose career has been diabetes and informatics and AI. Last year was the year of GLP-1s for diabetes and GPT for AI. And so I just happened to be at the intersection of those two things. But I think the thing that's been really striking for me or in the diabetes space, and I think, connected to AI, is that about 5 or 6 years ago, the first closed loop insulin delivery system came out. And so prior to that, as an endocrinologist, when I met with people with type 1 diabetes, as we've talked about, a lot of the work to be done was downloading 50 pages of data of their glucose, every, minute by minute glucose reading and minute by minute insulin delivery. And my job was to go through those downloads and to determine how well their insulin dosing was working and to try to make adjustments based on the patterns that we saw. Well, 5, 6 years ago, the first automated insulin delivery systems came out, which quote unquote closed the loop, which meant that as patients' blood glucose levels changed, the device had an algorithm that was automatically dosing and adjusting their insulin every few minutes. And at the time, I remember thinking, I'm toast as an endocrinologist. That what does a person with type 1 diabetes need me for anymore now that they've got automated insulin delivery systems? And what happened is that I was completely wrong. What happened is I sit down in clinic with patients. Their insulin I no longer have to try to be the computer algorithm determining the matching of, we still make modifications, but it's much easier now. And I no longer have to act as a computer algorithm trying to adjust their insulin to glucose algorithms. And instead, I could actually look people in the eye and talk to them about their life with type 1 diabetes, their fears, their challenges, their struggles, their goals, and spend more time doing that. And so that experience was really foundational for me as I, spent the rest of my career focused on what AI could do across the healthcare system, because I saw firsthand that AI wasn't actually going to take jobs away, and AI wasn't actually going to replace what humans love about being part of the healthcare field. It was actually going to make us better, and actually remove the really hard grunt work that maybe is not best suited for humans to be doing, but allow us, coming back to the Eric Topol quote, really restore the doctor patient relationship and really allow us to focus on the patient in the way that we all wanted to.
So just to go back a little bit in time, you mentioned the UCSF Epic install. Love to hear, first of all, your role and the lessons you learned from that project. I know it was many years ago.
Yeah, it's been a minute.
When you were installing Epic, whatever, 2010s or prior to that, did you ever think that this is where it would all lead?
That's a great question. Well, I had the greatest experience as we were implementing Epic. As I mentioned, I was straight out of residency. This was my first quote unquote real job in the world. And I was the front lines of our Epic implementation. So all of the build, all of the training, all of the provider workflow development, it was on me. It was an incredible opportunity for someone early in their career to truly be on the front lines in that way. And I learned so much. I learned about workflow design and making sure that you really understand the workflows that you're building for, and that you're not just throwing solutions at something without understanding what problem you're solving for. I learned a ton about change management and how to understand your different stakeholders, your providers, your care teams, your medical assistants, and driving communications and change management. I learned a ton about product thinking, and again, like how to understand the core thing, throughout my career since then has been fall in love with the problem and be flexible on the solution. And so it was an incredible time, an incredible opportunity to get engaged in informatics that early. Did I know where I was headed at that point? Definitely not. Although I will say, a couple of years after that, I had the opportunity to be on the founding team of a nonprofit for an organization called Tidepool, which is still doing great work today, that builds software in the diabetes space. And I think at that point, I sort of realized where I was headed, which is at this intersection of, too often in the care delivery environment, we pit patients and doctors against each other. An extra phone call into the clinic is more work for the care team. An extra in-basket message is more work for the doctor. Having to document your note after seeing a patient is more work for the doctor, even though all of those things benefit the patient. And I think what I came to believe during those years is that with the proper systems design, we could actually create systems that help doctors and patients together and help them achieve what they're both after, which is the best care, the best quality, the best experience for patients, without putting more work on care teams. And so I think that belief was really what I formed early on in those early informatics years, and has carried me through to today.
Yeah, I love that. It almost goes back to what Ken was saying. These are all tools, and patient care is the ultimate goal. And I love to fall in love with the problem, and be flexible on the solution. Definitely gonna relate that to the rest of the company.
Yeah, I think some of the key lessons are are broadly applicable to informatics and health IT at large. So some of the ones that stick with me are being connected to the business problem or pain. So it is very easy to fall victim when you're working in IT to being solution focused and, having what looks like a cool idea or shiny object. And then when push comes to shove, if it's not actually connected to solving the problem, you're going to miss the mark. So, very early on in our Epic implementation, one of my jobs was to spend dozens of hours building out all of the smart sets that we had been instructed to build for our providers. And then came go live in the first few months, and lo and behold, nobody used them. And I was I was pretty crushed at the time because I had spent literally months building those all out. But it was instructive because we hadn't actually spent the time to understand why they might be needed, how people were going to use them, and so it violated a really critical rule of thumb in informatics. I think another piece was being really mindful of how to provide decision support in a way that's tightly integrated and non-interruptive. So many times I see people immediately equate the term decision support with an interruptive alert. It turns out those are, interrupting someone's workflow is by far the worst way to try to get them to do what you want. And so, luckily over the last 10 years, we've seen much more attention to this, at Penn, they call it their nudge unit, but much more focus on choice architecture and sort of like from the behavioral economics field. What are the ways to embed default choices in people's existing workflow to influence their behavior? One example from our work at UCSF here, this one always cracks me up. We saw people choosing the wrong thing for CT abdomen pelvis. So people want to order a CT abdomen and pelvis, and we saw more than 2/3 of people actually erroneously ordering a CT abdomen. Well, we could have constructed an alert that said, hey, are you sure, when people choose a CT abdomen, hey, are you sure that you want to order a CT abdomen? Because we don't think you do. And you know what would have happened? People would have said, yes, that's exactly what I want to order. And they would have blown through the alert. Instead, what we discovered by looking at the workflow is that the first choice in the list was CT abdomen because it was in alphabetical order. And so no wonder people were choosing the first thing in the list because they're busy. And so we actually just added an extra space to CT abdomen pelvis to move it to the top of the list. And immediately the next day, the ordering frequency reversed and inverted, and people started ordering the right thing. They started ordering the abdomen pelvis appropriately. And so taking a minute to actually look at the workflow and look at ways to embed the right nudges, the right defaults into the provider workflow is by far the most powerful way to influence behavior and influence the care outcomes you want to get.
No, you're absolutely right. And I've heard so many similar discussions when it comes to examining workflow and just realizing people are creatures of habit, and the surest way to get them to stop using software is to interrupt everything they do, right?
That's right. And I think, that lesson is carried through to Notable, because over the years as someone leading digital health at UCSF, of course I was pitched every digital health solution on the market. And so often, it goes back to what I was saying about the diabetes software portals. People's goal was to design what they felt was the greatest user experience. And whatever it was for providers, if you just click over here to our beautiful user experience, we're going to make things so much better for you. But what they missed was that's not actually the provider's workflow. They already have a workflow in the EHR. And so the turns out like the most impactful thing you can do is to be invisible and to do, to move work forward in ways that's meaningful, but without interrupting, without asking people to go into another part of their workflow. So I'll give you an example of this that I just hit a couple of weeks ago. One of our popular solutions at Notable is around risk adjustment and finding additional helping providers accurately code their HCC codes for risk adjustment. And again, I think there's a lot of companies that create another user experience and say to providers, "Oh, it's really easy. You just come over here and use this thing." Well, I went to one of our customers and went to 3 of their clinics and met with a dozen or so of their providers and asked them how the deployment was going. Were they having any challenges? What was going well? And they looked at me with completely blank stares, like they had no idea what I was talking about. And they said, "What deployment? What are you talking about?" Well, turns out that was the best news I'd ever heard, because our entire goal was to embed natively in the Epic BPA that they were already using before Notable ever came along, and to surface codes that they are missing in their native workflow. And so them noticing nothing different is perfect. That's a successful informatics implementation. Is the users are doing the right, it's just like the CT abdomen pelvis. The user's doing the right thing, but you're not beating them over the head with it. You're not asking them to change anything about what they're doing on a daily basis.
Thanks again for listening to Quick Hits, a healthcare technology podcast for healthcare technology professionals. Follow us on Spotify or Apple Podcasts, and don't forget to reach out to us with feedback, suggestions, or even people in the healthcare technology industry you think we should interview. Send an email to quickhits@healthdatamovers.com.